You can see the first slide.
Yes, I can see the first slide. Yeah.
On my presentation.
Yes.
Good. And this is joint work with a group of us at UCL, at the Institute of Child Health, working on a particular project to do with special education need. And if you participated to the meeting last week, my colleagues Ruth Gilbert and Kate Lewis presented the creation of the data set for which I will discuss an example. So why target trial emulation? Of course, some of you probably have already some expertise in this, that you may have worked, certainly read papers about it, because in the last 7 or 8 years, there has been an explosion of publications based on this approach. It's not a completely new approach. It was really spurred by a publication in 2016 by Miguel Hernan and Jamie Robbins. But that paper just puts out the framework of something that was already there in the early 2000s. But the plot that the histogram you see here shows just a very quick snapshot of papers that mention target trial emulation, either in the title or in the abstract, from 2016 onwards. And you can see there is a sudden increase in the last few years. And why is it adopted? It is adopted to address comparative effectiveness research based on non-experimental data. And most of the applications that I found when I did that search had to do with pharmacoepidemiology. However, more recently, there have been more applications, or a few applications, in health policy evaluation. And this is because more and more frequently we have access to data that allow inquiries to do with public health evaluation based on observational linked data. So the outline of my workshop is to, first of all, introduce you to sort of the principles of target trial emulation to see how this is relevant to health policy evaluation, and then to work through an example, which is based on this project that we have called HOPE, that was discussed last week. And then I'll leave a few points of discussion. I have a few extra slides, so don't be worried. I'm not going to talk over 25 slides. The slides at the back are there for if there are any specific questions. So I'm going to go quite briefly over many concepts, and then it would be nice to cover them again. Or you can, if you will have access to the slides, you can look at them in your own time. So health policy evaluation and how to deal with it. It's often said that well-conducted randomized trials are the gold standard for assessing all possible of causal investigation, but in particular, when you want to compare the effectiveness of treatments, that will be in pharmacoepidemiology, or interventions, as we do in public health very often. And although this is stated as a sort of gold standards, there are several limitations to use the randomized controlled trials as an approach to answer questions of comparative effectiveness. The first one is that generally the inclusion criteria and the way in which randomized controlled trials, even of policy evaluations, are run, are limited to the access to the population, to restricted population of patients, restricted population, for example, of children in certain schools, if it's a policy evaluation to prevent bullying in schools. Also, RCTs have usually very short follow-up times, and this reduces the type of outcomes one can study. And if you work in life course epidemiology, certainly you want to look at very long-term outcomes, and RCTs are very unlikely to have the funding to run for so many years. And as we've seen with the COVID pandemic, often you want answers quickly without having to wait for the running of a randomized controlled trials to its full course before evidence is gathered. And finally, RCTs could be unethical. You should not randomize people to harmful exposures or interventions, and often are very expensive. In addition to these criticisms, which are very well known and often cited, sometimes one doesn't really click onto the fact that RCTs suffer from biases as well. And one of the biases is loss to follow up, which is that to mean that they're not immune to a typical bias of observational cohort studies, for example. And second, a sort of additional limitation of RCTs is that they would only target, they can only allow us to make causal statements about the effect of being randomized to a particular intervention, not necessarily to have received that particular intervention. So the intention to treat analysis, which is the standard reported estimates from RCTs, answer a very specific question, and it is, what if a certain intervention happened in the population, but not necessarily whether that intervention, the effect of that intervention has received. On the other hand, if we use the observational data here, more generally labeled as real world data, meaning anything else which is not arising from a highly controlled clinical data, and may include medical records, hospital admission, disease registry, all linked up, hopefully we're all linked up with also economic data, employment records, school records. All these data have a broad catchment of participants and usually are not that affected by issues about long-term follow-up, although there are often constraints when you start linking different data sources on how long the follow-up is actually achievable. They are generally less costly, but it could be costly. It all depends on which country you are, I suppose. And in a sort of positive spin as well, is that they're very useful to see how intervention or treatments impact on under real world consideration. So in a pragmatic sense of the intervention, not in the idealized setting of a randomized controlled trial. And as you can see, there's a however coming up here, and that however, as we all know, is that observational data, real world data, are not created under experimental condition and therefore are potentially affected by various biases. And this slide very quickly lists the three main sources of bias, and for the sake of time I will go quickly through them because I'm sure you're very familiar with them. And the first one is obviously confounding biases. Interventions are not randomized, but they are observed, and the mechanism of reception of choice of a particular exposure of intervention is driven by many factors. Not all of them may be understood. Selection bias is another very likely limitation of using observational data, and as well as being driven by what population you can catch through, say, linkage. There are issues of missing data, and which are obviously also well known and usually affect less of the RCTs. But sort of the additional point that I would like to make here is that selection bias can be a consequence of poor design. So poor understanding of your data, poor understanding of the question you want to ask may lead to selection bias. And there are examples in the literature, and you see them referred here, one of which, the most important one, was the debate about the impact of HRT, hormone replacement therapy, on risk of cardiovascular disease in postmenopausal women. And there, the original publications based on observational data were based on a poor design, a poor definition of exposure, and therefore poor inclusion of participants. The third source of bias is information bias. And again, here I'm sort of putting something which is well known next to something which is more specific to handling of real world data. The first one is obviously measurement and misclassification error. They may arise because data are not collected, usually for research purposes, and therefore entering of information, say, on ethnicity, could be very much affected by the care of whoever is filling in the health record when a child is admitted to hospital, for example. So that's well known again. But the additional point in the second bullet point here is mishandling of the data. And that's something, again, has been highlighted in the debate about how to use efficiently observational data for causal inference. And that's when, for example, information on exposure or treatment which is collated and from administrative data may be erroneously backdated to the start of follow-up time. And that's what goes under the umbrella of immortal time bias. And that happens when really there is poor understanding of the data, poor understanding of when the information should be attached to which time. So these are the three main sort of sources of bias, and they come from different, in different flavors. So how can we avoid this bias? Well, what we learn from RCTs is that they obviously don't suffer from confounding bias and generally don't suffer from selection and measurement error bias. But why? Because they're designed before data are collected, and they're designed through protocols that define the entry criteria and therefore the population to which the causal question is referred to. They define clearly the intervention or the treatment and a priori before the data are collected. So there isn't this problem of mishandling of the timing of the intervention. There's a clear definition and measurement of outcome and follow-up. And all of this, most importantly, that's what I want to stress, is done. This protocol is defined before the data are collected. And as we know, observational data that we analyze to answer causal questions of any time and policy health evaluation in particular are based on data that already exist. So there is a lot of data manipulation that comes, and the temptation of using data that are not really appropriate may affect our representativeness, the representativeness of our conclusions. So that's where target trial emulation comes into play. In their paper in 2016, Hanan and Robbins proposed a formal approach of handling observational data, adopting the same principles of RCTs in the sense of designing the protocol before looking at the data. And that's, I think, is the key point. And now I'm going to go into the details of how this happens. So just to rephrase what I've just said, this is a framework for non-experimental data. It's nothing new. It's just a way, good epidemiologists, good researchers have always thought very careful about how to handle observational data. But this is a framework that at least gives you the steps to check that what you're doing when you're using administrative data or more general observational data collected from linkage are avoiding biases which are due to your own manipulation as opposed to the natural bias due to confounding that we cannot control. So what does this framework do? Copies what RCT protocols do. RCT protocols, first of all, articulate the question, says, what is the comparative? What are we going to find out? Is this intervention effective in reducing, changing the risk of cardiovascular disease? Then they design the study to address that particular question, and that will require defining the population, defining the outcome, defining the exposure, defining the follow-up. And third step, the analysis, statistical analysis defined ahead of the data gathering so that you already know what you're after. You already state, these protocols already state what the target of estimation is and what the analysis in general terms will be. So what target trial emulation consists of? A first step, which is formulate the question straight ahead. Second, pretend that you could design an ideal trial. So filling a protocol as if you had the money, as if you had no ethical considerations, and you could design a study that would address the question you've asked in step one. The third step is checking whether you could actually translate that ideal trial into a pragmatic trial using the data that you have access to. You may find out, that's why there is this arrow out here, that you don't have the data that would answer that question, because maybe you don't have way of assessing that intervention that you really would like to study from the data you have, because the data you have are much coarser than the question, the level of exposure, the intervention, say, against bullying. So you go back to step one, reformulate your question, adapt your ideal trial, and finally, when you say, well, I've got the data, I've got the data fine enough to be able to emulate that trial, you start designing it. So more specifically, when you have the question, you fill in these 7 steps of the protocol of the idealized trial. So this is the ideal trial. And you say who is included, how long do you recruit them for, how long do you follow them up, what's the outcome, what is the level of treatments of intervention you want to compare. Here I say what is the estimand. The estimand is a more of a technical term. I should say the causal contrast of interest. You want to say, is it the risk ratio? You want to say between exposed and unexposed, between those intervened and not intervened, or do you want to know whether it's the effect in terms of risk difference or prevalence difference in different levels of exposure. And then you define the analysis plan, how those estimates can be actually estimated from the data. You've done this, you then emulate it. So you'd see how much of these 7 steps can be actually emulated from your data. By doing this, it's the causal question, the first thing you ask. It's not, oh, I'm going to use logistic regression with my data once they're linked. You think of the question, and then you design the analysis, design the data gathering and the analysis steps ahead of looking of the data. And that will avoid many biases and will make sure that you don't start comparing levels of exposure which are not those corresponding to the original question you had. And finally, because everything is written down and explicit, you can cross-check with colleagues, with other collaborators, whether you're introducing any biases, for example, by misclassifying exposure level, by backdating what the data are telling you to the beginning of follow-up. This is sort of the general principle, but I thought the best way to sort of illustrate, to really stress how this works is to go through an example. And I'm using the example that Kate Lewis introduced to you a week ago, if you were lucky to join the session last week. But very briefly, what we are doing now in the HOPE project at the Institute of Child Health is to study the impact of special education need provision in certain population of children in need, where the definition of in need is quite complex. But just for simplicity, what I will consider now is a particular group of children who suffer from major congenital anomalies, and that's what Kate presented. But just to clarify, what do I mean by special education need provision? It's extra educational provision that is different from what is usually available to pupils. It's not delivered at just one level, but a different level of intensity. It could be just an extra teacher support in the classroom to help certain children to read, or it could be actual intensive one-to-one help in smaller classes, maybe in special schools. And the provision, unfortunately, is not homogeneous. There's a bit of a lottery there, and it depends on the school's budget, on the school tradition and support of teachers, by the local authority budget. And there has been policy changes over the years that also affect how the provision is given. The group of children in need that I will discuss today are children affected by major congenital anomalies. There will be anomalies that are detected at birth or soon after birth. And what is known about them, that about sort of 2% of births are in 2020, according to registry data, were of children with major congenital abnormalities. They go with a wide range, as you will see in the next slide. And these children receive more of special education needs than the general population. So about 40% of these children were recorded to have SEND provision in primary school in this 10 years of data that we have access to, comparing with 25% of those without any major congenital anomalies. So that's one example of children in need of special education needs support and provision. So this slide, you've seen it last week, and shows, first of all, let me just focus on the left-hand side, the provision I was just describing now. So this is the 25% of children with no major condition, congenital anomalies receiving sense support of some type, while this is the distribution of 40+% of children with any MCA. The different colors represent gray, the lowest level of support, which is in mainstream school and sort of the class level. Blue is in mainstream school, but with EHCP, which is extra educational support, and red is special school attendance. And you can see there is a differential there. The different grouping in the graphs show different groups of disease conditions that go from nervous system anomaly to eye anomalies, etc. But the group I will discuss now is because we are considering these children in separate groups because of the heterogeneity of their needs and the heterogeneity of their provision, are those with cleft lip and palate anomalies, so orofacial anomalies. And you can see there is quite a high proportion of support for them, up to 70% in those with cleft and palate, and slightly a lower percentage in those with a slightly lower in lower needs. So there is a degree of severity going from left to right here. And you can see the equivalent change in support. So I'm going to look at these children and consider the question whether SEN provision improve their health outcome. Because, of course, we would expect SEN provision will improve their educational outcome, but in this presentation, I will focus on health outcome because these are children in need, physical need, and with great disadvantage in terms of their health. And we hypothesize that SEN support will also improve the way in which they access healthcare, and that would also improve their health status overall. In the data set from the eChild data set that was described last week, identifies 6,000 children with these conditions, and I already said that the severity depends on their specific defect and this obviously impacts on how much provision is given to them, as I've just said. But there are other factors that influence whether or not and what degree of support they receive, and that obviously depends on social disadvantage, with the understanding that higher social class parents will be more vocal in asking for greater support. There's a differential by sex, depending on the different distributions also of the defects, the school characteristics, the policy changes, the month of birth, and the test results in primary school. So all this will influence the impact. So now the last few minutes are dedicated to try to do this target trial emulation to answer this causal question. So the question is, does SEN improve the health outcome of these children? Where now we need to specify what is SEN support, what are the children, and what are the health outcome, how long we are going to follow them up without looking at the data. We are trying to imagine, if I wanted to answer that question, ideally with a lot of money, no ethical issues, I would like to include all children with a diagnosis of cleft lip and palate before they start primary school. That's when SEN provision starts. And I consider a particular period of time when these children attend primary school. And I will recruit them between this period, as I said, between the academic year 2008, 9 and 2014 and 15. So I'm just considering a period of time where they're in primary school and early enough to allow me to follow them up until a certain date, until they reach the end of primary school, which would be 5 years later. The outcome I want to consider to see whether the health outcome is improved or not is unplanned hospitalization. So number of episodes of number of days, of unplanned hospitalization, because of course these children will require hospitalization because of their disease, but it's the unplanned hospitalization that could be reduced, or the rate of, if SEN provision improves their speech and interacting ability, so that they can vocalize their needs, for example, or that there is greater support for their greater understanding of their needs. For simplicity, let's consider that we just consider randomization to whether or not to receive SEN support in their first year of school. And there could be 3 levels: no support, lower level of SEN, and this higher level of one-to-one intervention or ECHP. What is the causal contrast or estimate that I'm interested in? I want to see the average causal effect of those treated versus non-treated. I will develop this in the next slide because I just want to finish the protocol first. And I will express this in terms of rate in number of days. So it will be a ratio of hospitalization, unplanned hospitalization. And because of expected extra dispersion in the number of days, I will use a negative binomial model. That's my hypothetical ideal target trial. Let's try to translate that into the emulated trial. So now in red, you see the difference, how the emulation occurs. First of all, earlier I wanted all children diagnosed with CLP. Now I can only say children identify in HES. This is because I'm going to use the eChild database, which I forgot to remind you, I should have said it earlier, is a fantastic resource which links hospital health records with school records. And the hospital health record allows us from birth onwards to identify those with certain conditions. So through HES, so the records in HES, in the hospital health statistics database, we can identify children with this condition before school starts, before year 1. But there will only be those identified in HES. It could be that not every child with CLP is identified in hospital, but we have done various checks and we are pretty sure that we identify most of them. But the next condition that affects our emulation is the attending state primary school, because we only have linked to NPD, National Pupil Database, which only includes information on primary school. So we are missing any child with CLP that goes for private school. So we see our eligibility criteria already identifies a source of potential selection bias. The recruitment period is the same, the follow-up period is the same as in the trial, but we also are limited by the follow-up information according to the school records, because we want to, and also to the completeness of the hospital records. The outcome is the same. The treatment, again, has a limitation, which is due to SEN, not just as random. Before we had randomized SEN support, SEN provision. Now we have SEN as recorded in the National Pupil Database. So again, another possible sort of misclassification, because we only know what is recorded. The causal contrast is the same, the analysis plan will be the same, but we'll have to control for confounding. Now I realize that I only have 1 minute left, but I think I'm reaching the end, because the last slide I want to discuss is discussing the estimates. So this will be open for discussion, how this emulation may or may not be successful in a particular example. But writing the steps in full makes you realize where the biases can arise and may help you, for example, in discussing with your colleagues how you actually identify the exposure level, may help you identify where possible sources of bias there may be. Sorry about my computer reminding me of other things. So the last slide is this. Let's think of what comparison really, how do we translate that generic question, does SEN improve health conditions in these children? How does that become a quantity that we want to estimate? What are the policy relevant causal questions? That's probably what you want to discuss more than anything else. That generic question that I had could become 3 possible different questions or 3 joint questions. The first is, what really are the benefits for the children who did receive SEN? You may want to say, well, I've got my data set is limited. I may miss the children who go to private school and had CLP. So let's just consider the population of children who we know have received SEN and ask, was that a good policy for them? Or I would ask, or could ask the second question, what about the children who are not recorded to have received SEN? Should they have received SEN? Would have benefited, but they were left out? And the last question could be, what would be the consequences of a new policy? Let's say you imagine a new policy that gives SEN to everybody, every child with CLP, or maybe a subset of children with CLP of the most severe condition. And if you want to translate that into a quantity to be estimated, which we call causal contrast or estimand, these three estimand come about. The first is called the average treatment effect in the treated, the ATT, would be the quantity that addresses the question, what are the benefits of receiving the treatment or the intervention you have received? And we could have another full session about how you estimate it from the data, but I just want to discuss the target of estimation. The second question will be addressed by the estimand called average treatment effect in the non-treated, because it tells you what would happen if they were treated, but that we know they were not. And we know, because this is not a randomized experiment we are dealing with, we can ask this question because there are some who probably would have benefited, but the system somehow didn't offer the provision to them. And the last one is the interventional treatment effect, which is a way of imagining a world where you implement that policy and you using, obviously, again, quite sophisticated causal inference methods, you can see what will be the impact of that particular intervention you designed under some very strong assumptions. So this brings me to the end, and 3 minutes over time. Estimating the health effects of policy is practically important, and otherwise you wouldn't be here, I'm sure you agree. Combining the TTAE framework with linked health and educational data is enabling us to try to ask these questions. Of course, answering these questions is complicated, and we need to face all the sources of bias that will arise. And by playing with the protocol, however, we may be able to highlight what the source biases are and whether you can address them or not. But the lesson I've learned by doing this application, we start having some results that I cannot divulge yet because they're not been approved yet, but we are finding from this experience on this particular group of children that it's so important to discuss all the details of the data with the data scientists that create the linked data. There are so many items of concern that I would have not been aware if I hadn't spoken with them very, very careful. So this is group science. It's definitely something to do in great collaboration. And this brings me to the end. And I can show you there are some references here and then some additional slides open to for you or perusal.